right, you all, welcome to the lecture over the knee joint. For our knee joint, we have a couple bony properties to analyze here. So remember, moving from the hip, going down more distally on that femur bone. Here at the knee joint, you notice that we have the condyles of our femur articulating with the enlarged tibial surfaces that receive those femoral condyles. You'll also notice that we have this fibular bone. This would be located on the lateral aspect. Again, the fibular bone will be important attachment sites for our biceps femoris, as well as that IT tract. And remember that IT tract is the extension of that TFL muscle located on the lateral aspect of our hip. And as far as the main bones, those are essentially it. We have our distal aspect of our femur, our proximal tibia, and our fibula head. You'll notice once we get into the actual joint sites, the main articulation, of course, will be between our femur and our tibia. When we engage in weight-bearing activities, that transfer of force will come essentially from the hip core region. Remember that our SI joints is crucial for dissipating those forces about our hip, going all the way down to the femur, and then responsibilities will be thus transferred to the tibia. So our fibular bone won't actually aid in weight-bearing activities per se. It's mainly between the femur and tibia bones. For the knee joint, we'll look at three main joint sites. Our first joint site is obviously our knee joint proper. In anatomical language, this will be our tibial-femoral joint. Again, these are the femoral condyles articulating with the tibial plateaus. You'll also see that these plateaus are also called condyles located on the tibia. So don't be confused if you see tibial condyles. Those are just referring to the plateaus that we see here on the proximal tibial bone. Now for the knee joint, we are dealing with a modified hinge joint. How I'm presenting the information to you is that the knee joint is a uniaxial joint, simply meaning that we are only analyzing the flexion and extension action occurring about the sagittal plane. Now you'll also see some references saying that the knee is able to internally and externally rotate. And this is true. However, it depends on the context in which you're analyzing these external and internal movements. For example, you'll see in the lower leg lecture that we are able to evert and invert our foot. If this is done while the knee is flexed at a joint angle of greater than 30 degrees, you may be able to see the knee joint also engage in some minor internal and external rotation actions. However, in the most practical sense, the knee joint is indeed able to internally and externally rotate. However, we only see this when the knee is either locking out or unlocking and beginning to engage in a knee flexion. I'll explain these concepts later on in the lecture. Also be aware that it's called a modified hinge joint because there's also that rolling, spinning, and gliding action. You guys may remember this during our first section of the course when we talked about open chain and closed chain movements. And of course, this is a synovial joint. So not only do we have this ability to freely move our joint, there's also increasing mechanisms to make sure that our knee is stable. I say all this to say that the knee joint is the most complex out of the joints that were analyzed off the course and arguably the largest joint site. Next, we have our patellofemoral joint. Our patella is the largest sesamoid bone and is embedded in the quadriceps tendon. This is also referred to as our kneecap, and its main function is to, one, protect the anterior aspect of the knee joint. You'll notice that we have critical ligaments that help stabilize the joint intrinsically. So not only protection, our patella bone essentially increases our mechanical advantage. Remember, our mechanical advantage simply means that it maximizes our force producing capability. You'll especially see this during knee extension, really helping out our quadriceps muscle group. Our quad muscles essentially indirectly attach to the patella, and through the patella, the official attachment site will be in the tibial tuberosity. And it is done that way via the patella ligament. The presence of this patella bone increases the mechanical advantage the quadriceps has in extending the knee. For the patella specifically, it articulates with the femoral notch or intercondylar groove of the distal femoral bone, and this is located between the femoral condyles. This GIF here is simply illustrating how the patella articulates with the intercondylar groove of the distal femoral bone. Again, this is the largest sesamoid bone as it lies on the anterior aspect of our distal femur, emphasizing the main function of the patella bone besides providing protection to the knee joint on the anterior side. You notice that each of our four quadriceps muscles attach on some aspect on the patella bone, and it increases the quadriceps muscle's advantage as it essentially extends the attachment point to the tibial tuberosity. The force action by our quadriceps muscle is occurring about the tibial tuberosity. Last of the joints here, we have our proximal tibiofibular joint. Just by the name, you know that we are looking at the proximal attachment between our tibia and our fibula. Again, our fibula is located on the lateral aspect of our lower leg. And although this is a synovial joint, it's very stable, not very movable. Once we move down more distally, you notice that just like what we see in our radius and ulnar bone in our forearms, the articulation between our tibia and our fibula is brought on by a couple of different attachments. We have our proximal and our distal attachment, and we'll also have this interosseous membrane that kind of runs in between the shafts of these bones. We'll also see some slight anterior and posterior gliding, as well as slight rotation actions occurring about this joint. However, this joint site does not directly aid in our knee flexion or knee extension actions. Moving on to ligaments of the knee, we'll start off with our collateral ligaments. This is following the same premise with our other collateral ligaments that we see around our body. This will be located on the medial and lateral aspects of our knee joint. And their main function is to support the medial and lateral aspect of the knee. Our medial collateral ligament will actually insert on the medial epicondyle of the tibia, as well as some fibers of our semimembranosus and medial meniscus. If there's a particular mechanism that causes the medial collateral ligament to rupture or strain in any way, you may also have some issues with the medial meniscus as well, because some aspects of the ligament attaches to the medial meniscus as well as the tendon of the semimembranosus. Our lateral collateral ligament resists forces occurring on the medial aspect of our knee, also known as varus stress, and its origin and insertion points are the lateral epicondyle of the femur and the fibula head. We've gone over our MCL and our LCL. Now, if we go more deeper, stripping away the patella bone, you'll notice that we have two ligaments that cross each other. These will be our cruciate ligaments. The ligament that crosses on the anterior aspect will be our anterior cruciate ligament, and the ligament that crosses on the posterior aspect will be the posterior cruciate ligament. Now, of these two, obviously, our ACL will be our most notable, and it technically originates on the anterior medial aspect of our tibial condyle, and it travels up to the lateral condyle of the femur. And this prevents the anterior translation of our tibia or the posterior translation of our femur. And it is also incredibly crucial in rotational stability. For our posterior cruciate ligament, again, we're seeing this view from the posterior aspect. It prevents the posterior translation of the tibia on the fixed femur, or it prevents the anterior translation of the femur on a fixed tibia. Obviously, how we move around and ambulate, the ligament that is asked to do the most will be our ACL ligament, hence why it is more prone to injury. A vast majority of ACL injuries are non-contact in nature, and this is due to excessive stress placed during planting and rotation actions. You'll often see ACL injury occurring while an individual is trying to plant and cut. They come down, and then trying to cut is essentially trying to load and engage in some sort of rotation action at the same time. And this may be related to the Q angle, in which we'll talk about here in a moment, the hamstring to quadriceps ratio. This is the ratio pertaining to the strength between your hamstrings and your quadriceps group. The usual ratio is that your quads to hamstring strength ratio will be extremely high. But the hamstrings muscle group is a muscle group that essentially does the same actions that the ACL ligament prevents. And going off on like a sports science side of things, us here in the Institute, we do Orlando Magic testing. And one of our main tests is to test this hamstring and quadriceps ratio pre-injury and post-injury, just to make sure that these ratios are optimal. And regarding ACL injuries, the main muscle group that can help to protect further ACL injuries is to make sure that our hamstring strength is increased and up to par with our quadriceps muscles. It also may be caused due to hip strength. Again, whatever deficiencies we see occurring about the hip may go down the kinetic chain, and it may have our knee in a position that is more favorable for an ACL injury to occur. It may impede our anatomical alignment, and of course, obviously, previous history and trauma may also cause the ACL injury to occur. I don't know if you guys are old enough for this, but Johnny Manziel, tearing his ACL, you kind of see the moment where his knee just kind of popped, and he's engaging in this planting and lateral translation, right? So he's planting and trying to rotate at the same time. It's usually a perfect situation for an ACL tear to occur. Some knee alignment terminologies. Again, we have our knee valgus, but this is the caving inwards of our knees. Notice here that this is a force pushing on the lateral aspect of our knee, which causes this inward concavity of our knee joints. Again, guys, this also may occur due to weak musculature up here, which causes our knees to cave in, which automatically has implications as far as our foot mechanics are concerned. And if there's any issues as far as our foot mechanics, every time we step, cut, run, the ground reaction forces may cause further issues. I'm just saying that to illustrate the importance of our kinetic chain as a whole. Not only do deficiencies about our hip causes alignment issues down our body, it may also cause us to expose ourselves as far as ground reaction forces are concerned. We also have knee varus. This is our bow-legged stance. Every time you see the word genu, it's referring to the knee. Popliteal will be the posterior aspect of the knee. And we also have our pes, which means our foot. Whenever you see the knee valgus alignment, this also falls under another broad set of alignment issues known as the pronation distortion syndrome. Let me go back up here. And with the pronation distortion syndrome, you'll have this knee valgus occurring about our knee joint, and it causes the ankle to move away from the midline of our body, and it essentially collapses the arches that we see at our feet. So every time we move, we're exposing our feet to more ground reaction forces, simply because our foot is unable to properly dissipate those forces. So when we see this flat footiness, it is called pes planus. Our normal foot will have this normal medial longitudinal arch about the foot. And conversely, we also have this pes cavus, which is a high arch. Again, either the high arch or the flat feet will cause some issues as far as dissipating ground reaction forces. And again, this is just a picture referring to how we would use the word genu. It just refers to alignment seen about the knee and the sagittal plane. Our acute angle is the angle formed by our quadriceps and patella tendon. And this is just simply the line of force of the quadriceps muscle. Notice here that none of the actual muscles that make up the quadriceps originate on the anterior superior iliac spine. Our rectus femoris insists on the anterior inferior iliac spine, but just know that the line of pull travels through, at least on the more proximal side, up through the ASIS and down right through the patella bone. Normal values range from 10 to 20 degrees. Females will have, on average, higher QL angles compared to males, and this is mainly due to females having wider pelvises. However, a QL angle greater than 20 degrees can predispose an individual to injuries, especially about the knee joint. Another important mechanism here is the screw home mechanism, and this is describing the minute internal and external rotation actions occurring about the knee while the knee reaches full extension. As I mentioned before, the knee joint is classified as a modified hinge joint, and the main actions occurring here is knee flexion and knee extension. The only times where we see this internal and or external rotation action occurs when the knee is locking out into full knee extension and also unlocking to engage in knee flexion. So during the last 20 degrees of knee extension in an open chain movement, the tibia will externally rotate on the femur, or in a closed chain movement, the femur will internally rotate about the tibia. These small internal, external rotation actions mainly occurs because, and we talked about this acute angle, in order for the knee joint to fully lock out, those two bones have to be in line. So those minute internal or external rotations, depending on which bone you're analyzing, allows for the femur and the tibia bone to be fully in line, which allows the knee joint to lock out during full knee extension. From that locked out extended position, the knee may also unlock, and it does so by either the tibia internally rotating in open chain movement or the femur externally rotating in closed chain movements in order to allow for knee flexion to occur. The muscle responsible for essentially unlocking the knee is the popliteus muscle. So while the knee is fully extended, the popliteus muscle contracts, and this contraction will cause either the tibia to internally rotate or it will cause the femur to externally rotate, unlocking the knee and allowing the knee to engage in knee flexion. Any alignment abnormality we see, especially here at the hip or the foot, will cause issues up and down the kinetic chain, right? These images are essentially illustrating the importance of kinetic chains and even highlights some common alignment distortion issues. A prime example here, if we have weak hip abductors, it's causing that ipsilateral hip dip that cause the femur to internally rotate. This internal rotation of the femur will cause this knee valgus action about the foot. And because the knee valgus action is occurring, there will be an internal rotation about the tibia bone, as well as a more lateral translation of those lower leg bones. This lateral translation will cause abnormalities in the foot area. In this case, we'll probably see a pes planus or a flat foot. And this is a result of the collapse of the arch that we see about the foot. And when we don't have that arch, whenever we walk, run, or jump, the ground reaction forces that are realized about the foot will become more jarring, especially as it moves up the kinetic chain, mainly because that arch is not there to properly dissipate those forces. Same thing occurs when we have this lowered cross syndrome, which is essentially just the opposite of what we call the pronation distortion syndrome. Getting into the muscles of the knee, this is very straightforward. A lot of the muscles here we already covered in the hip lecture. The only difference here is that we are analyzing these muscles action occurring about the knee joint. So for knee extension, our main muscle group would be our quadriceps muscle. So along with our rectus femoris, which also crosses that hip joint, we also have our vastus muscle group. This would be our vastus lateralis, our vastus intermedius, and our vastus medius. Our vastus intermedius muscle will be found more deeper compared to our rec fem, our VL, and our VM. And they all act to extend the knee. Again, they insert on the tibial tuberosity via the patella ligament. And just to make myself clear again, from a direct standpoint, the quadriceps muscles attach via the quadriceps tendon to the patella bone, and with the patella acting as a sesamoid bone, it increases the mechanical advances of the quadriceps by essentially extending the insertion point to the tibial tuberosity via the patella ligament. Another important muscle here is our sartorius. And just like our rec fem, our sartorius crosses the hip joint and also inserts on that medial aspect of our knee joint and also aids in knee flexion. The quadriceps group as a whole is responsible for knee extension. However, for hip flexion, the only muscle of the quadriceps muscle group that acts on the hip will be the rec fem. And outside of the quadriceps, another extrinsic muscle that acts on both the hip and the knee will be our sartorius. For muscles responsible for knee flexion, this will be our hamstrings. It's also noteworthy to point out that our quadricep muscle is responsible for knee extension and hip flexion, and our hamstrings are responsible for knee flexion and hip extension. So for our hamstrings, we have our three muscles. We have our biceps femoris, our semitendinosus, and our semimembranosus. Remember that our hamstring muscles, all three of them, originate on the ischial tuberosity. As we move down more distally, our biceps femoris muscle will insert primarily on the fibula head. Remember, our fibula bone is located on the lateral aspect of our lower leg, and our semimembranosus and tendinosus insert on the medial aspect of our tibia. Remember, this will result in different actions as far as hip external or external rotation is concerned, but see how we're just talking about the knee, just know that all three of these muscles are primarily responsible for knee flexion, at least in the upper thigh. As you move down to the main muscles of our lower leg, you'll see our two heads of our gastrocnemius muscle. When these bad boys contract, they also flex the knee. Now, a couple more deeper muscles of note will be our plantaris and our popliteus muscle. Now, our plantaris muscle assists with knee flexion, but is of little importance as far as really contributing to that action. Our popliteus muscle is the muscle most important in unlocking the knee, especially once our knee is in that full locked out knee extension position. So from that position, our popliteus muscle will contract. It will cause that tibia to internally rotate and begin the process of knee flexion. Other muscles that act on both the hip and the knee will be our gracilis and our adductor magnus muscle. Now for the gracilis, this muscle aids in knee flexion, hip abduction, and hip internal rotation. So you can kind of put this in the category of the sartorius as far as another extrinsic muscle that helps in knee flexion. And the hamstring portion of our adductor magnus muscle will help in that knee flexion action. Other muscles that you may not be familiar with also having some implication about the knee joint will be our gluteus maximus and our TFI muscle. And this mainly happens because of their insertion point to the IT tract. And this IT tract is essentially just a band of fascia that actually attaches here on the lateral aspect of our tibia as well as the head of our fibula. Not too much contributions as far as knee flexion and knee extension is concerned, but just know that the attachment sites of these muscles do have an indirect implication on the lateral aspect of the knee. Other major landmarks to consider here, we have our Gerdy's tubercle, and that is the lateral bony protrusion of the tibia. And this is where the IT band inserts. Again, we have our tibial tuberosity. This is the insertion of our patella tendon. And then we also have this area where multiple muscle tendons insert on the medial aspect of our knee. More specifically, this will be the semitendinosus, the sartorius, and the gracilis. Each of those muscle tendons will insert on the medial aspect of the knee in an area called pes anserinus. Another important structure we see in the knee is our meniscus. We have a medial and lateral meniscus. The medial meniscus is characterized by this larger C shape, and the lateral meniscus is characterized by this smaller C shape. Both have this concavity nature, and by that, I mean that the most outer rim is more dense, but as we get more medially into the tibia bone, you notice that it essentially wears to the articular surface. The meniscus is attached to the condyles of the tibia, by the way, not the femur. And just like how we see here with other labrum structures, it's used to deepen the tibial condyles to increase the surface area. The main function, of course, is to provide that stability and further promote the proper transfer of force. Due to the complexities that we see about the knee joint, of course, we have our joint capsule. As I mentioned, is covered by this fibrous outer layer, and the inner makings of this knee joint will include that synovial membrane. We also have various bursa, which is essentially around the actual bones that make up the knee joint. And we also have our various fat pads that are located strategically around this joint to absorb forces and impact. Just a minor review from the blood supply and nerves that I went over in the hip lecture. We have this popliteal artery. The popliteal artery is an extension of that femoral artery, and you'll actually see this running down between the femoral condyles on the posterior aspect of the knee. All you need to know here is that we have the popliteal artery here. It's a continuation of the femoral. You also see that it gives off various genicular branches. These genicular branches provide blood supply in and around the knee joint. Pretty straightforward there. And then as far as the nerves, again, we have the common peroneal, also referred to as common fibular, and we have our tibial nerve. These nerves are the branches of the sciatic nerve. The bundle of the sciatic nerve is actually the combination of these two individual nerves. Right before you see the fibula head here, so right around this area, you'll kind of see the bifurcation point where the tibial nerve will move on the posterior aspect of our lower leg, and our common peroneal nerve will move more so on the lateral aspect. Once you get into the lower leg lecture, you'll realize how those nerves play important roles in innervating muscles that move our ankle and our foot. And that will conclude the lecture. Thank you all for your attention.